This lecture is about biology of tooth movement. Human dentition has maxilla and mandible. This pic shows the anatomy of tooth. Outermost layer enamel followed by dentin pulp chamber, and the root is covered by cementum periodontal ligament alveolar bone, and the apex has apical foramen through which blood vessel and nerves supplies tooth. We are going to see about physiological tooth movement, which is naturally occurring tooth movement, and orthodontic movement and its mechanism. Physiological tooth movement are naturally occurring tooth movement, which occurs during tooth eruption, migration of teeth. Changes occurs during mastication. Eruption occurs through growth of the root and forces from the periodontal ligament. Orthodontic tooth movement occurs through remodeling of the alveolar bone in response to prolonged mechanical forces on teeth. Bone resorbs on the pressure side and forms on the tension side of the periodontal ligament. Tooth eruption is the axial movement of the tooth from its developmental position in jaw to its final position in oral cavity, and it has 3 stages: preemptive, eruptive, and post-eruptive. Theory of tooth eruption: blood pressure theory, root growth theory, hammock ligament theory. The tissue around the developing end of the root is highly vascular. This vascular pressure is believed to cause the axial movement. Root growth theory states that tooth eruption occurs because the root of the tooth grows in length. As the root develops, it pushes the crown of the tooth upward toward the oral cavity. According to the hammock ligament theory, a ligament located below the developing tooth acts like a hammock. As the root grows, this ligament becomes stretched and tense. The tension created in the ligament pushes the tooth upward, leading to tooth eruption into the oral cavity. The periodontal ligament, PDL, traction theory states that tooth eruption occurs due to the tractional force generated by the periodontal ligament fibers. These fibers pull the tooth occlusally towards the oral cavity. Tooth migration is the movement or shifting of teeth from their normal position in the dental arch due to various physiological or pathological factors. When food is chewed, occlusal forces act on the teeth. These forces are transmitted to the periodontal ligament, PDL. The PDL fibers compress and stretch, allowing slight movement of the tooth. The alveolar bone and PDL absorb and distribute the forces, protecting the tooth and supporting structures. Histology of tooth movement describes the microscopic changes occurring in the periodontal ligament, PDL, alveolar bone, and surrounding tissues when a tooth moves due to force. Pressure side. When force is applied to a tooth, PDL fibers are compressed. Blood vessels constrict. Osteoclasts are activated. Bone resorption occurs in the alveolar bone. Backhand index pointing right. This allows the tooth to move in the direction of the force. Tension side. PDL fibers are stretched. Blood vessels dilate. Osteoblasts are activated. New bone formation occurs. Backhand index pointing right. 1. Pressure, tension theory. Most widely accepted theory. Concept. Orthodontic force creates pressure on one side of the periodontal ligament, PDL, and tension on the opposite side. Mechanism. Pressure side. PDL is compressed. Secondary remodeling changes during histological tooth movement include reorganization of PDL fibers, bone remodeling, repair of blood vessels, cementum repair, and reattachment of Sharpie's fibers. Bone remodeling during tooth movement involves bone resorption by osteoclasts on the pressure side and bone formation by osteoblasts on the tension side, allowing the tooth to move in the alveolar. Tooth changes following the application of excess force during tooth movement. Compression of periodontal ligament, PDL. Hyalinization of PDL, glassy, structureless tissue. Occlusion of blood vessels in the compressed area. Tissue necrosis due to loss of blood supply. Undermining bone resorption from marrow spaces. Delay or temporary stoppage of tooth movement. Damage to surrounding periodontal tissues. Possible root resorption in severe cases. Pain and discomfort due to excessive pressure. Tooth overall changes following the application of excess force during tooth movement. When excessive orthodontic force is applied to a tooth, abnormal histological changes occur in the periodontal ligament, PDL, alveolar bone, and surrounding tissues. Tooth optimum orthodontic force. Optimum orthodontic force is the minimum force required to produce maximum tooth movement without causing damage to the periodontal tissues. Characteristics: produces efficient tooth movement, maintains normal blood circulation in the periodontal ligament, PDL, causes bone resorption on the pressure side and bone formation on the tension side. No tissue necrosis or hyalinization occurs. The phases of tooth movement are initial phase, lag phase, and post-lag, acceleration phase, which occur due to biological changes in the periodontal ligament and alveolar bone after orthodontic force is applied. Initial phase occurs immediately after force application. Tooth shows rapid movement within the periodontal ligament space. Movement is due to compression of PDL and displacement of fluid. Lag phase, delay phase. Tooth movement slows down or stops temporarily. Hyalinization of PDL occurs in areas of heavy pressure. Necrotic tissue is removed by macrophages and osteoclasts. Bone resorption begins from adjacent marrow spaces, undermining resorption. Post-lag phase, acceleration phase. Tooth movement starts again and becomes continuous. Bone resorption on pressure side and bone formation on tension side occur normally. Tooth moves steadily in the desired direction. The phases of tooth movement are initial phase, lag phase, and post-lag, acceleration phase, which occur due to biological changes in the periodontal ligament and alveolar bone after orthodontic force is applied. Theories of tooth movement: pressure-tension theory, bone bending theory, piezoelectric theory, fluid dynamic theory. 1. Pressure-tension theory. Most widely accepted theory. Concept: orthodontic force creates pressure on one side of the periodontal ligament, PDL, and tension on the opposite side. Mechanism: pressure side. PDL is compressed. Blood flow decreases. Osteoclasts activated. Bone resorption occurs. Tension side. PDL is stretched. Blood flow increases. Osteoblasts activated. Bone deposition occurs. Result: tooth moves through bone by resorption on pressure side and formation on tension side. Bone bending theory, proposed by Farrar. Concept: alveolar bone is elastic and bends slightly when orthodontic force is applied. Mechanism: force bends alveolar bone. This bending creates areas of pressure and tension, stimulates bone remodeling. Key point: bone itself participates actively in tooth movement. Piezoelectric theory, also called the bioelectric theory. Concept: when bone is mechanically stressed, it produces electric signals, piezoelectric currents. Mechanism: compression of bone, electric charges generated. These signals stimulate osteoblasts, osteoclasts, leads to bone remodeling. Important feature: electrical signals occur immediately after force application. Fluid dynamic blood flow theory explains tooth movement through changes in periodontal ligament fluid and blood circulation. Mechanism: orthodontic force alters PDL blood flow. Causes: release of inflammatory mediators, cellular